Of our 23rd annual Lefeber Winter Series on Aging. I'm your host, Elena Volpe, and this lecture, as you know, honors the memory of Dr. Edward James Lefeber. He started essentially geriatrics on this island in a long time ago, 1939. He taught medicine here at the UTMB and became the director also of what was at the time the Turners and Moody House, which is now the Meridian Retirement Community. Before he died, the UTMB developed the geriatric division, which has been thriving ever since. Today we're really fortunate of having here Dr. Mark Hayward. He's the Centennial Commission Professor in the Liberal Arts and a Professor of Sociology, the Director of the Population Health Initiative, a Faculty Research Associate and Graduate Training Director in the Population Research Center at the University of Texas at Austin. He earned his bachelor's degree in sociology from Washington State University in Pullman, and then he went got his master's degree in sociology and a PhD in sociology with a minor in economics at Indiana University, Bloomington. And then he became a research scientist at the Battelle Memorial Institute of Seattle, after which he became an assistant professor of sociology at the University of Washington. And then he decided to move all the way to the south, to the University of Southern California as an associate professor. But after that, he decided to go east. And so he went to Penn State University, where initially went there as the director of the Center on Aging and Health in Rural America. And he was promoted to full professor, and then became the director of Population Research Institute and the Social Science Research Institute at Penn State, where he was also named a distinguished professor in sociology and demography. And finally, in 2005, he moved to UT Austin as the director of the Population Research Center. His research focuses on health disparities with a particular focus on the impacts that policy changes have on population health, and is collaborating with a lot of investigators from here, from Galveston, so with Dr. Markides, Ottenbacher, Wong, and a lot of other people. As research has been continually funded by the NIH, the National Institute of Health, since the early 80s. And he has published more than 100 papers in 9 peer-reviewed journals, and has served as a reviewer and chair of NIH study sections. He has received a number of honors and awards, among which the very prestigious Matilda White Riley Award that the NIH Office of Behavior and Social Sciences Research awards to honor individuals whose research has contributed to behavioral and social scientific knowledge and the application of such knowledge relevant to the mission of the NIH. So this is a big deal. Dr. Hayward is also a teacher, has mentored many graduate students. And so we're really honored to have him here as a speaker for our Lefeber Winter Series on Aging. And his talk is going to be about institutional policy changes and the growing inequality in U.S. health and mortality. So, Dr. Hayward.
Thank you. Thank you for such a wonderful introduction. It's one of those situations where I really wish my wife were here to hear that I actually did pretty good over the years of my life. First of all, I want to thank everyone for a delightful day. I just had a great time. And then I wanted to give you a kind of warning. I'm in the throes of a cold, so my voice will probably come and go, and I will do my best. And then the other part is I'm in the last stages, I think, of growing of having a cold, but I'm in the first stages of growing a beard, which means I'm not very nice to look at, and I may not sound very good either. So my apologies as we kind of launch into today's discussion. Interrupt me. I'm quite interruptible. If I don't get to the last slide, it really doesn't matter, does it? So I'm actually while this looks like about me, it's really not about me. It's really about us. So I almost never do anything all by myself. I get lonely in my office, and so I have to wander around and find collaborators. But I am working with a group of researchers from across North America, and they're a quite diverse team. And I'm going to tell you a little story about Jennifer here. Jennifer is the project director at Syracuse University. She was my graduate student years ago at UT. There's me, of course. There's Anna Zachikova, who's a former postdoc of mine, who's now at the University of Western Ontario. Stephen Wolfe, you may not know. Those of you that are part of the National Academy of Medicine will probably recognize Stephen's name. He was the study director for the NRC studies, which documented where American mortality was relative to all other high-income countries. So he really was a quite instrumental person. But he's an MD, right? So he's joining this group of people. And then we have Jason Beckfield, who's from Harvard, who's a policy person and also a historian and a sociologist. So we have a quite diverse set of people because we have a pretty complex topic, which is how public policy and a changing America are shaping our health. And it's not for the faint of heart when you get into this stuff. The devil's in the details, right? You think, oh my God, how did we get into this? So here's my story. So how did we get into this? Years ago, Jennifer was doing some runs for me. She's a good graduate student, math major as an undergraduate. Always take graduate students who are math majors as undergraduates. That's my philosophy. They're wizards. Anyway, Jennifer runs off and she goes, Mark, look at these kind of growing inequalities that we see in mortality, especially among women. And I said to Jennifer, I said, well, that's great. What it was is this kind of classic way of thinking about things. Oh, low-educated women's mortality is like 2 or 3 times that of high-educated women, something like that, right? I said, well, that relative stuff, that's all great. What are the real numbers? Like, what's going on with the real mortality rates and the real life expectancies? And she comes back and she goes, well, I can't actually quote what she said, but because we're in a public forum and I'm being filmed, but she's to the effect was, holy cow, women's mortality rates are actually going up in the low education group in like real numbers, right? So women in the low education group in the United States, starting in the 1990s, were losing life expectancy. This is not supposed to happen in a developed country, right? This is the kind of thing, it's not going according to how we think about ourselves. And yet, starting in the 1990s, we saw this and we were going, oh my goodness, what does it mean? So little did she know that at the time of doing those very primitive runs, we launched a major project which now has resulted in a 5-year NIH grant, and we've just been publishing up a storm about these topics. But it's big, and we need a lot of expertise, and we're probably not done roping people in terms of collaboration. Today I'm going to talk to you, nothing I'm going to talk about is rocket science. There may be a few figures I'll talk you through. If your cortisol levels go up, I'll get them down. Don't worry. What are the key facts about a rapidly changing relationship between education? And I choose educational attainment mostly because it's a great marker for socioeconomic inequality. What comes after? You get a good education, what's the result? Whether it's the sequela of a good education, right? So we're going to talk a little bit about that. And here's the punchline. Many Americans are increasingly at risk, while other Americans are living longer than ever before. So we have this rapid widening in inequality in the United States between the haves and have-nots. And I don't mean that just necessarily in terms of money, I mean that in terms of life expectancy. So, the other thing I want to investigate, and this is really unusual, demographers, that's what I am, is really a demographer. We deal a lot with data. Theory is really not our forte. We leave that to other disciplines. But we got into this because something had to explain the magnitude of the changes that we were observing out there in the world. And I will tell you, there was no ready-made theories off the shelf that we could just go grab and say, oh, it must be this, right? We actually started parsing the data in many, many ways and kind of backed into this kind of set of observations that I'm going to share with you, which you may or may not believe me today, and that's okay, because we're still evolving, and I'll take questions and I'll take criticism, because as I said, this is still a kind of project in the works, and I think what I will say is that the world is not in equilibrium, and for those people who are economists, they know what equilibrium means, but what I mean by that is the world is constantly changing. And so every time we think we have a handle on something, that something changes in an important way. And so what we know or we think we know, stay tuned, folks. You're kind of in for a rocky ride, and we certainly are for a rocky ride in what's going on with American mortality. Some of you may have seen news reports. Life expectancy has stalled in the United States. It has stalled. It's been stalled. It's even going up a little bit. Underneath that is the turmoil I'm going to show you today, where we have basically offsetting kinds of phenomena going on. The well-educated are doing better than ever before. The poorly educated are doing worse than they ever did before. And we're talking absolute census. The ultimate goal I want to try to convince you of is that we have had the emergence in very recent years, right? It hasn't taken long in the United States that we have the emergence of what I would say are multiple Americas. And I'm going to try and give you really concrete examples of what I mean by multiple Americas. And I'm going to talk to you particularly about the way in which U.S. states' institutional policy changes are becoming more important in shaping trends in inequality and population health. What I don't want you to do is to think about who's the evil person and forces behind this, because there is no evil behind this. This is an American phenomena. It's due in large part to the way we think about public policy, the way our relationships have evolved between states and the federal government over time. So much of this, what is going on, I'm going to talk about today, was extremely well-intentioned, right? It's just that we never ever thought there would be some downstream consequences that are playing out on the ground, which have quite negative consequences for some people and pretty good consequences for other people. Okay, so I'll try to convince you of that. Now, you think we'd have the facts and just the facts already down, right? There was a paper by J.L. Shansky and colleagues that was published, I don't remember when, I should know the exact date, because I pick on this paper all the time. And they had some phenomenal number that women over some period of time had lost over 5 years of life expectancy. Well, I don't know about you, but if you're a demographer and you say we lost 5 years of life expectancy, essentially war, disease, and famine has to happen in your country in order to lose 5 years of life expectancy. So we got in there and dug in the data, and it's not 5 years. It's significant. But 5 is a lot, and it's an unbelievable number, right? I'm thinking, did anyone review that? Actually, I did review that paper for science, and it didn't get in there. But I said, did anyone actually review this paper and think about what those numbers meant? Because you really would have had to have catastrophic changes in order for us to actually lose the numbers. So, you read it in the newspaper, it must be right. Well, not always. So I'm going to talk to you about the facts, right? And I also want to mention about what does education do for you? I was talking to someone today. There's a paper that we wrote a while back. It basically has a really formal title, but the subtext is, can a good education overcome a bad childhood? It can, by the way. But these are the ways in which we think about education. And by the way, I don't know if Ken Lange used this slide or not, but Ken stole my slide. At least he attributes the slide to me. But this is the way in which education, we think, is working in terms of ultimately affecting health and mortality, in terms of the kinds of individual level behaviors in which we are engaging in, which is this educational attainment means a lot for having valued information about lifestyles and healthy lifestyles and healthcare, right? Life is complex out there. The more educated you are, the better off you are to deal with these complex issues. And it's not rocket science to say, hey, I need a good education to have access to jobs that have high rewards. If I don't have a good education, those jobs are not accessible to me. Not rocket science. What is interesting, though, is there's another component to education, which is I have access to these valuable networks. And perhaps increasingly so in a technologically advanced society. So let me just give you an example from my parents who have passed, so I don't have any human subjects problems at the moment, maybe family embarrassment, but other than that. So my dad had called, he was talking to his neighbor, Chuck the contractor. Chuck the contractor, next door neighbor, had 10th grade education. My parents basically graduated from high school, which meant they were really in the upper echelon of their birth cohort, but still only high school. And their neighborhood was people just like them, right? Their social network, in fact, my parents hosted happy hour pretty much every night in Yuma, Arizona, which I call blue collar Palm Springs. So Chuck the contractor says to my dad, well, you know, what'd the doctor say about your wife, my mom? And Dad says, well, I have to put her on Coumadin, which is a blood thinner. And Chuck the contractor said, what? Coumadin? That's rat poison. You are poisoning your wife. So my dad stopped giving my mom Coumadin. Okay? Just stopped. My sister, the doctor, hears this. She says, I can't deal with him right now. You have to talk to them. I go, yeah, you turn it over to the boy to talk to the parents. So I called my father and I said, you know, how did you hear this? And he said, well, Chuck showed me the internet site for where this was the case, right? And I mean this in a quite real sense. That's my parents, right? And I got my mom back on Coumadin, everything is cool. But they needed a well-educated child to do it, by the way. Suppose they didn't have me, which is the other part. Here's the contrast. A buddy of mine I went to graduate school with said, I don't want to be a damn sociologist. I want to run a major marketing company and cater to Fortune 500 firms. And he did. He has a major marketing company. And one day I get a call at the office and he goes, Mark, my wife has a very rare form of cancer. He says, I know you're on some boards at MD Anderson. Can you help me? I made a call, one call, to the right person. And within 2 hours, the consult was set up, the plane reservations were made, they had a hotel reservation right by MD Anderson. Okay, see the difference, right? I'm not Chuck the contractor, and I can reach into where I can get the care. That's what education did for my friend, right? But that's where the lack of education did for my parents, just as an example of how this is working. Now, I may not be a good example of sophisticated cognitive skills. You'll have to be the judge of that. And my sense of control, I do have an overinflated sense of control, and I have this illusion that I have human agency in what I do. And all those, believe it or not, are good for me in important, visceral ways. Now, here are the facts. We actually went back and re-estimated all those life expectancies. And here's the life expectancy at age 25 by years of schooling, and the schooling is people who have more than 16 years of education or more, 12 years of education, and then basically high school dropouts for the most part. Now here's the brouhaha about women, and it's really about white women. So white women in 1990 had a life expectancy almost 55, 54 point something. By the year 2010, white women who were low educated had dropped in life expectancy from about 54 point something to below 51. So there was real loss in life expectancy over that period. For men, there was a little dip, but it's hard to pick up, okay? Now, this is the story that captured the imagination. This is where I'll show you.
This is 50 years of additional life?
Yes. So, this is the life, if you're 25 years of age, what is your life expectancy at that age, okay? So life expectancy for an adult who's 25 years old. What's going on with college educated people? This is a story that New York Times never wants to cover. They only want to talk about this. They never want to talk about this. But notice what's happening over this time period, just on a national basis. These are pretty simple numbers. Educational differences aren't so big here. They're really big here, and they're growing. And I will tell you, actually, we have updated numbers, and they're continuing to grow. And they probably will grow even more. And if I trusted the data to break it out into beyond college, we'd probably see even more heterogeneity above the college degree. So there is some pretty major stuff going on under the surface here. Now, don't freak out yet. Let me see if I can explain this graph. So remember, we had what's going on. So we want to know, let's just take this bar here. What's going on with the change in women's life expectancy over that time period? And what ages are women losing or maybe gaining life expectancy? Maybe it's different by age, right? So here's actually the example for those women. So what we did was we said, okay, at what ages, we just said, we have that big number for life expectancy. At what ages are they losing or gaining life expectancy? And for women in that education group, they lose life expectancy at every age. Now notice, here's the opioid epidemic, okay? And there is certainly an effect of an opioid epidemic. But you know what? What about them? And what about them? And I will tell you, what about them? Which is 12 years of education, right? So at the younger ages, for high school, we're really losing. High school and below are really losing life expectancy for women. We do see some gains for older women, right? And as you move up the educational ladder, people are gaining life expectancy. Remember those numbers? They're really gaining in life expectancy if you move up over that time period. Well-educated people are really taking off. Look at well-educated women. They're gaining life expectancy at every age, and they're especially gaining life expectancy at the oldest ages, right? Pretty amazing. The same pattern goes on for males. Now, this is what you can hide with statistics. You say, okay, if you look at males down here, there's really like no real change, right, in life expectancy over that period for less educated men. And you say, well, the story's all about women, right? The story's all about women. Well, not really. Because what you had is a situation where there were some gains in the older ages and the younger ages that balanced out the losses in life expectancy in the middle ages. So it pays to look under the hood, so to speak, when you're looking at some of these numbers, so you can begin to identify where in the age range, what kinds of causes are involved. Look at causes of death. It's really critical to begin to understand and construct some facts, right? Not just hearsay, oh, I made up the story that's consistent with these data. No, demographers are actually possessed about let's get the numbers right. So we'll spend a lot of time getting what looks to be not very interesting numbers, but we think they're important. Look at males. Look at these well-educated males. They're really gaining in life expectancy at all ages. So, and these are just white Americans. I could show you black Americans, but the story is very complicated, and I'm not going to go into that story today, but I will answer questions about what's going on among black Americans' mortality if you want to use them in the Q&A, assuming I have a voice. So, something big had to happen out there in the world. And we started reading things like economic history. This is not something I was looking forward to reading late at night or on the airplane. I'm usually like beach novels, right? I like fiction. The lighter, the better. I really am fluff for brains, if you really want to be honest about it. But we started reading issues in economic history, and the economic historians have really done a good job about talking about the kinds of changes that happened over long periods of time in the United States and other places in the world about what's going on. And one is simply that we've had this massive infusion of technology and institutional knowledge We know how to manage health, right? We know the ways in which making people better. We know how to prevent the onset of diseases. We know how to manage them, and we know in some ways how to cure some of them. So there's a lot that we know out there in our institutions, and we also know that not everything is medical. So the things that make you sick are not necessarily the same things that keep you maintained and maybe improve your health once you're diagnosed. So we know a lot about that stuff, right? Vaccines. I'm going to show you some pictures, some ideas about the kinds of inputs, technological changes that occurred over the course of the 20th century. So I never really thought a lot about this, but I'm thinking more about this now. Here's the one I never, ever, ever thought about. And this is the one that we're actually more possessed about now than ever before, because this story, the role of technology and institutional knowledge, is really about national institutions. If you will, in some ways, federal institutions and federal government, kind of general knowledge out there in the world. This issue, the role of public and health policies, is actually operating at multiple levels. So we have a federal process of federal policies, and we have actually states. And I'm going to tell you what happened. There's a kind of odd and interesting relationship that happened between the federal government and the state government that no one was paying any attention to, least of all me. The last thing is, and I'm never going to talk about this today, is the demography. So the demography of the United States has changed in ways, and we can get into that as well, because it's really about what's going to shape more of the future and less of the past. But all of these kinds of major factors have implications for what we think of as this simple little relationship between educational resources and your health outcomes. But all those things are shaping those relationships, right? And in fact, now, more than ever before, education is more important than it ever was in terms of both presenting risks to you and providing you with resources. It's never been as important as it is now. So I crowdsourced. I was bad. I was on Facebook one time and I said, I'm reading all these economic histories. I need some real flavor to this whole thing. And I'd done my historical research, but I put out there on crowdsourcing on Facebook, I said, what do y'all think? I have a lot of friends. Some of them actually think they know more than they do. But I said, what happened in the course of the 20th century that might have influenced major health trends in the United States? So, they were just popping in, like left and right, just popping in. We're going to talk about this issue of technological innovation and the rise of the New Deal. That's really defining the early part of the 20th century. It kind of launched us off into being a modern society. And then I'm going to talk about the Great Society and the culmination of the New Deal, which is in the Johnson years. And then I'm going to talk about something that almost none of us have ever thought about before, which is this issue of what we call new federalism and the federal devolution of power back to U.S. states. The feds began in the 1970s to give control and jurisdiction over major social programs right back to states. And it's at that point that we began to see a lot of things happen in the United States. None of that is bad, inherently bad. It may be bad for health, but it's not bad per se, right? We're not talking about the evil hand of something happening out there. We're really talking about the unintended consequences of very reasonable policy debates and changes out there. So just keep that in mind, because people have a tendency to kind of over-attribute or make negative attributions about something, and they're really not true. The other thing to keep in mind is that some technological and institutional changes promoted improvements in health and reduced disparities, which is good. That's what we all want, right? We'd like to improve health and reduce inequality. But other changes, especially recently, have led to declines in population health and rising disparities. That's what's been coming up in the newspapers, right? So here's part of my crowdsourcing from Facebook. And don't look at the specifics. I'm just going to talk about what happened. So this is a period running from basically the early 1900s that ended about 1940. And we've just called this era technological innovation and the rise of the New Deal. And during this time, we had all sorts of things that happened that would actually improve population health. So we actually had meat inspection. We figured out the existence of different blood types. We had refrigerators for home use. Guess what? That's a big deal, right? And as I'm about to do a kitchen remodel and lose my refrigerator, I'm extremely thoughtful about what a refrigerator will do for my health in the next few months. But we had things like vaccines, but not everything moved forward, so we had the Spanish flu epidemic, right? The point is that a lot happened. Vitamins, insulin, vaccines for children, TB vaccine, penicillin, frozen food processes were a real boon to public health out there in the world, right? So we had both medical, technological advances, and we had kind of large-scale technological inputs to people's well-being in terms of sanitation that were really, really important. So don't forget, we actually had TVA, the Rural Electrification Act. Thank you, Lyndon Baines Johnson. How many of you are you must all be Texans, right? Okay. Never. God bless LBJ. I'm telling you, every Texan should go to the LBJ Ranch. It should be required of everyone, and I swear to God, it should happen twice a year. And there are reasons for that, because when you go to the ranch, and I'll show you in a minute, he had a profound effect on our nation in ways that we don't anticipate, right? But you see a lot of stuff that was going on that was really mass. Vaccines are mass, frozen food is mass, everything is countrywide, right? Then we had the Great Society, and this is what I mean by go to the ranch. Because at the ranch, someone said to me one time, how'd you get this idea? I said, well, I was looking at data. I couldn't figure the hell what was going on. I went to the ranch. I had some friends from out of town. I said, you have to see, they were going to move to Texas. I said, you have to see the ranch before you move to Texas. And the reason I started thinking about this was, at the ranch, there's a set of murals that run around the room that talk about what happened. National fluoride recommendations, Surgeon General's report on smoking, War on Poverty, Civil Rights Act, Voting Act, Food Stamp Act, Older Americans Act, Head Start, which affects children, Higher Education Act, which affects young people, Medicare and Medicaid established. It affects lots of people, prime-aged adults, poor people, older people. FDA approved the first oral contraceptions, began to control, women began to be able to control their bodies a lot more. Cigarette warning labels, tobacco control policies came into play. Beta blockers, that's good. Highway Safety Act. Deaths went down massively in the United States from traffic accidents. National Traffic and Motor Vehicle Act. You got it. EPA and OSHA established. If you think about institutions that were formed to provide inputs into Americans' health, to improve Americans' health, what you had at that time was a situation where the inputs into Americans' health were massive. They were just unprecedented in the history of this country. And in fact, when you think about things like inequality, I don't know if you know this. This time period, you know how you hear in the news people talking about income inequality in the United States right now is really bad, blah, 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 blah. You know when inequality was really low? Blah, 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 blah. So we've come a long way, basically, in terms of the income inequality. We're in a very different situation now. We have the rich people have a lot more of the overall dollars that are generated in the country, but we started out from a time period where we didn't have that much, right? We were pretty similar. Then we started with this new federalism, which is not a bad thing per se. The idea generally being is that states should know more about how to administer some of their social programs because they know what's going on at the state level. That sounds good to me. I don't know about you. And we're set up and we're organized in our Constitution of the United States to talk about federalism like this. because we have this relationship between states and the federal government. So it began with Nixon and Reagan. And what happened during that time was, why not just give states block grants? They can figure out how to spend the money. And on paper, it sounded really good. But the devil's always in the details, because the states weren't exactly set up to take the block grants. They could apply for the block grants. Every state hand was out for a block grant. Oh, hell yes. Are you kidding me? Who's not going to take money from the federal government? Everyone should. Does everyone know how to spend that money once they get the money into the block grant into their state? No. And there were very few guidelines, and the issues of accountability were a little weird out there in the world. So state differences in life expectancy began to grow. We have a geographic lens to our work. I never thought about geography, and I never thought about states, ever. Because when I was a baby demographer, who cared? It was the most uninteresting thing that you ever heard about. You know, if I looked at California, and I looked at the life expectancy at birth in California, okay, so it was a little better than West Virginia, but we're talking 1.6 years difference, right? 1.7 years difference, not a lot. New York, same kind of disparity, you know? Because I'm just picking two states you'd think one would have a really high life expectancy, one would have a really low life expectancy. They were different in expected ways, but they weren't that different. Okay. This is our physical activity break. So, I will tell you now that the difference, I think if I remember correctly, the difference between California and West Virginia is about 5.5 to 6 years. Just to put that change in context. So we're talking basically in the 1970s, not much difference, some difference. Now, a lot of difference. And we're not actually talking the most extreme differences yet. I'll get to those. So the 1980s, we had a lot of stuff going on, a lot of good stuff. I won't attribute any valence at all to the Human Genome Project at that point. I'm teasing. But we really got into full swing and giving states more power. This is a kind of states' rights issue, right? I mean, this is part of American politics. It's hard to refute a lot of this kind of conversation because it's part of our DNA as a country. But we have states now becoming responsible for major social programs like tobacco control, right? You'd think all the states are the same in tobacco control. No, not at all. Minnesota, you lived in Minnesota over this period of time, guess what happened? They raised those excise taxes so high, they were going through the roof, okay? And guess what happened to their smoking rates? Down, right? Now, what's interesting is actually Minnesota, the well-educated were just like the well-educated Mississippi. They saw that Surgeon General's report and they're going, hell no, we're not going to smoke. And the trend lines for the well-educated Mississippi and the well-educated Minnesota are exactly the same, right? Where are the trend lines different? So every time in Minnesota that they'd raise those excise taxes, the smoking rates for people that with high school education and less plummeted down, right? Because they're the ones that are most affected by the policy. In Mississippi, guess what? They didn't raise excise taxes. So their smoking rates, except for the well-educated, their smoking rates in the high school and less were really high, right? So now you wonder, I'm just picking one example. When you give states discretion over certain kinds of things, like tobacco control, it's just one of them. There's one of many things, right? States are going to make decisions based on their own unique situations about how to control or invest in populations or do whatever. States do that. Legislatures are really important in this process. So we had this recession. It created more inequality among the states. And I've got to tell you The recession also made it harder for states to fund their programs. So the federal government says, oh yeah, you got this program. The recession hits, the states go, we don't have any money for that program. The federal government says, well, we don't either. So states are left with a very hard decision, right? Rich states do well, poor states don't do so well. Creates more inequality, right? It just feeds on itself. Nothing intentional about this. In the 1990s, we had this Welfare Reform Act that occurred in the Clinton administration, which is, these welfare reforms created, gave states the ability to spend federal welfare grants at their discretion. So states gained more control. Some states did some things, some states didn't do other things, right? So the general story is, and I can't get too much into the specifics, some states made a lot of decisions that invested in their populations, and some states do not. That's the way life is in America. I will say that the EPA launched these environmental standards, and states began to realize that they actually, this is the NEPPS, I forget the acronym. There's a big fight between the EPA and the states all the time. EPA puts out regulations, the states decide whether they want to follow them or not, and they get fined. And the states hated the feds, and the feds hated the states, so they created a special organization to bring kumbaya moments between the states and the federal government. It never really worked. Anyway, the last thing I want to talk about is we have this program, which we never think about, which is called the Earned Income Tax Credit Program. And that's a program where it's really the biggest anti-poverty program we have going in the United States. But you may, if you fill out, you notice you don't have any state income tax. So you don't have state EITC. A lot of states have, on top of the federal EITCs, they have their own state poverty programs too, right? So you can see massive differences in social safety nets across the United States, in part just because of the kinds of laws and programs that people have. I come from the state of Washington. It's a lot like Texas. You know, if you think that they're ever going to have a state income tax in Washington state, over my dead body. It'll never happen, right? Think about that, right? But it takes a state income tax to have an EITC. I want to put the American states in perspective. You don't need to know the real numbers, but I suspect all of you know that this is Europe, okay? That's not a problem. Let me explain the color coding. The red is bad. Life sucks. That's the clinical term for it in terms of life expectancy, all right? This is the life sucks corridor of Europe, and this is the life is good corridor, right? So Spain has really high life expectancies. France has really high life expectancies. Italy does. Parts of Germany. Look at the Netherlands. We move into southern England. Look at, we have data, good data for Sweden. Life is good. Look at the darker the green, the longer you live. Okay? That's Europe. That's the United States. Same metric. Exactly the same metric. There is no difference in those colors, what those colors stand for. So, guess what we look like? Okay? We look like the corridor of death in Europe. I'm being facetious, pardon me. I've been sick, I'm tired. I'm probably going to talk out of school, but, maybe this will go viral on YouTube. You never know. I'll get a lot of points. Notice Minnesota has some green. A little bit like parts of France here. Not as green as Spain and Switzerland, and not as green. Hawaii has some green. But basically, we're not very green, are we? We're more of the kind of deep red, brownish. And all I can say is, in Texas, thank God for foreign-born Latinos who keep our life expectancy rates up. Because if it wasn't for them, we would be in the toilet. So believe it or not, it's that Hispanic paradox issue, right? Hispanics do live a long time. So they're not necessarily healthy, but they live a long time. Yeah. So Anyway, this gives you a perspective on why we care about states. Because, and we're putting this in kind of a international context, because now we were doing some life expectancy runs by state. Between the highest and lowest states now for women, I think the difference is over 7 years between life expectancy at birth for women in the highest and lowest states. In Europe, the difference is much less in terms of all high-income countries. So if I were to say, how does Germany compare to France and compare to the United States, it's about 4.5 years. So I've actually done more subunits here so that you can see kind of a little geographic richness in the whole thing. But that puts an American context, I think, into what's been going on in a much more kind of global context about where things are going. And a lot of times you'll hear people complain about where is the US relative to other nations in the world, and we keep slipping in the overall world global life expectancy rankings. We used to be 31st, but now we're probably falling. I don't know. Because other countries are really surging ahead. They're really improving. And we're either stagnant or falling behind in real terms. So I've just given you some examples here. This is female life expectancy at age 50 in 1990 and 2000. 10 years. That's all. Just 10 years. Not very long. Okay, here's West Virginia, Mississippi. Here's Oregon and Massachusetts. Yeah, I cherry-picked these states. Of course I did. The gap here, you can see, is between about 32 and about 30.5. So about 1.5 years between these states, right? What happened over a 10-year period? I mean, not very long. One state got worse, West Virginia. Mississippi got a little better. Oregon didn't do so well, and Massachusetts went flying off that way. Now, in 10-year period across these states, this is the variation compared to this variation, right? 10 years. Whatever we're seeing is happening fast. This is not a little slow glacial movement. I'm watching the glacier move down, the blah, 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 slowly melt away. No. We're talking about life expectancy that is not slowly going away. It's not a trickle. So I wanted to give you an example of some things that we've been doing in terms of the more policy stuff. So I think I told you about state excise taxes. I'm going to skip that in the interest of time. Actually, let's just go back. So here's how much states taxed people on cigarettes in 1990. Basically, we're not talking a lot of excise taxes. And this is the 50 states in terms of their variation. Now, between 1990 and 2000, look what happened. A lot of changes in the variation in states. And now look at 2010, and even more state variation in excise taxes, right? So what we're seeing over a very rapid period is really major changes in how we tax things like cigarettes, which we know have a dose-response relationship to kill us, all right? So I won't go through EITCs, but it's pretty much the same thing. We've seen a growth in EITCs, a lot of variability across states. Some states have none. Some states have a lot, right? This happened fast. If you think about these as like local anti-poverty programs, some states are really moving forward with the anti-poverty programs. Other states are doing nothing. So here's another part that we have been learning a lot more about, which I'm not sure how to think about. It's a concept called preemption. This is called state preemption of local paid sick days in nutrition and non-discrimination laws in the United States, February 2017. The idea being the state legislature or the governor could say in the state of Texas, no, Austin, you may not have stricter smoking laws than the rest of the state. You would have to adhere to the state. Now, I'm just using that as an example. No school district in Richardson, Texas, you may not have stronger nutrition standards for your school children you have to adhere to the state. The preemption laws are making places that want to do more investments or have stronger laws in terms of protecting population health toe the line. I thought, this is a phenomenon that we've just become much more acquainted with. I'll tell you that in the federal level, from the EPA point of view, I've even begun to think about this in really real terms. There was an act last year in Congress. Most of us, I'm sure this just blew by us. It blew by me. It wasn't until I gave this talk to a bunch of environmental toxicologists that they told me about it. They said, hey, we have preemption. Last year, there was this thing called the Lautenberg Act. And the Lautenberg Act said, hey, the EPA will establish the law of the land in terms of what are the requirements for testing for toxins and what kinds of products and chemical products can be put out into production and consumed and expose the American population to. The law of the land is the EPA. What it really meant is, no, California, you may not have stronger air quality control standards. No, Montana, you may not have stronger clean water standards. No. So it was reining in. It was an explicit attempt to rein in places that were really investing. They were meeting their own needs. If you lived in Los Angeles, I'm sorry. Somehow I've lived in LA. I like my state to be more proactive in terms of pollution standards. I live there. I know what the consequences of not being proactive are. And if I had to live according to the federal standards, I would be sicker, okay? This is going on a lot around the country. What I really want to show you, though, is who's really affected. So we published this little paper recently, which is we have these groups called less than high school or some college, and bachelor's or higher, and we have these very simple metrics of health. The percent of people with difficulty dressing or bathing, and down here are all the 50 states. We just arrayed them, all 50, okay? I don't care about identifying particular states. We're not going to do state shaming tonight. We need alcohol to do state shaming.
Well, we're going to have it.
Okay.
We can do it offline.
Yeah. But notice, here's the level of educational inequality in one set of states. And here's the level of educational inequality out here. Now notice, it doesn't matter what we choose. Whether it's bathing or dressing, whether it's difficulty doing errands alone, like an IADL, like it's vision difficulty, look at this. Look at walking or climbing stairs, hearing, cognition, self-reported health. Look down here. Look at this. These people who are less than high school are better off than those people with high school or some college, right? This is all 50 states. My point being, the well-educated, I'm sorry, it really doesn't matter where we live. Remember that little diagram I showed you about what education does for you? We have all the goodies. We have money, we have discretion, we have knowledge, we have control. We do whatever we damn well please, pretty much. And we understand what these kinds of phenomena do to us, and we make decisions every day that improve our health. We do. We just acknowledge it, right? But for other people, clearly, states are mattering. In terms, and we've done a lot of analysis, and there's other papers that are underneath this, which show the kinds of factors that are really involved down here. But the bottom line is, states that are investing in their populations look like this, okay? Everyone's doing well, pretty much, and inequality's low. It's not that you get rid of inequality. It's hard to get rid of inequality. Come on, that's not going to happen in this kind of social hierarchy world where humans are involved. We are humans, right? So the social hierarchy is with us. The point is that you can reduce, through policies and through investments, you can really reduce the inequalities out there And states are doing it. Some states are doing it really successfully. No, some states are not doing it so successfully. That's my general point here. I'll just continue. I'm not going to, there's enough of this stuff. Okay. So, it's really important to understand this idea about education and health. It's really dynamic. What we thought we knew about that relationship is changing. It's changing really fast, right? And it's changing not only over time, but it's changing over place. And place is often driving what we see at the national levels. You get these national life expectancy estimates. They're really driven by what's going on out there in the world in which we live and where we have resources or we don't have resources. So our argument is that in this case, states, not because of any bad inherent evils out there in the world, but in large part because we're Americans. States have become really important institutional actors. Now, I have to go to the Hill next week, not next week, but next month, to do some education work, right? So it's really important for me to think about this in ways that really reach into every Texan's heart. And I'm really thinking about where do we focus? And I think we focus on education. I have so much evidence about the downstream consequences. And from the well-being of the state of Texas, I want my state to do well. I want a rich state which is driving technology, which is, our economy is flourishing and we are a knowledge economy, and I want our state to really be, I'll be biased, I want it to be number one. I like living in Texas. Let me just be blunt. And we can be. But it's with those investments. In Texas, whether you know it or not, in our state constitution, we're committed to public education. It's there. Don't ever forget it. It should be part of our DNA. It should be part of every person's DNA in this room. So that's what I'm going to talk about. It's really about, let's invest in our kids more than anything else that's going to have real benefits for our state. It's going to have enormous benefits for our state. So I'm just going to stop. There's a great, Jennifer wrote a great op-ed piece that's published, and please share my slides. I've talked for a complete hour, and let me just say something else one more thing. Anytime the government says, this is American life expectancy, blah, 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 something's driving that change underneath. And we just realize that we have growing inequality. So if it's stagnant, it may mean that some places are getting better and some places are getting worse. But you got to figure that out. The other thing is, life is not like a randomized control trial. That's RTC is the jargon. So a classic academic will go, you need a randomized control trial to show me exactly how that one policy is going to change Americans' health in this state. And I go, okay. At the same time that policy was enacted, so were 3 others. Choose your poison. They're bundled together. It defies a traditional way of thinking about causality that we don't like, okay? We just don't like it. If you're at NIH, RTCs, randomized control, RCTs, they're like the name of the game. Everyone has to do them, right? Those of us that are bench people, you all know that in here. This is not like rocket science. But the other part is, change is the norm. It's not the exception anymore. That's the part we've got to get used to, and I think, in some ways, that's why I come back to education. Education helps us deal with change in a way that I think has some real positive consequences, and I'm done. So I'm sorry.
Very nice job. I think we have time for one question.
Oh, one.
Then
Good.
we can have questions over wine, and then we can unleash all the state shaming.
No state shaming. Yeah.
Were comorbidities factored out of the data you collected? And if not, were there any particular comorbidities that affected a particular socioeconomic status?
In terms of fundamental causes of disease, every disease is worse, pretty much, except for certain cancers, which are not as much driven by exposure. But any kind of heart disease, any kind of neuroendocrine diseases, and diabetes, you name it, those are all exposures. And that's really, so rich people don't have those things as much, and poor people do. So from the comorbidity standpoint, did we explicitly look at comorbidities? No, and it's impossible in our data, right? I mean, I have to go into a secure data enclave anyway to actually do a lot of this work. Not the most fun place in the world. Kind of like a monastery, only with fewer benefits. So anyway, so no. But I'm not sure that you can do comorbidities in this. But we know from everything else that we've done for 40 years that this all tracks in terms of social inequality. What do rich people get? A lot less of than poor people. So rich people are really similar across all these states, right? They're really similar. Now we might vary in terms of mortality because the quality of healthcare will vary across states. That's true. But in terms of underlying dimensions of health, no. So, anyway, thank you so much.
You two are working together to work wonders.